Okay, so I'm going to discuss options and tips for localization. This is my perspective. Okay, so we're going to discuss hologic localizer system. And what is it? Well, it's a wireless radio frequency identification system that is used for wireless lokes. There's a radio frequency chip, which is encased in a 10 by 2 millimeter ferrite rod, which is wrapped in copper and encased in glass. This glass is covered in an anti-migratory sheath that is placed in the breast. Each tag has a unique ID number that is displayed on the reader device. And this tag can be placed with a mammographic, stereotactic, or sonographic guidance. So what does it look like? This is the small radio frequency ID that the tag is what I call the tag, which is placed in the breast using this 12 gauge needle applicator system. And then this is the reader device that identifies the unique tag ID number. This is the device that Dr. Blackwood will talk about that she uses in surgery. I just use the needle applicator and the localizer device. So what are the advantages of the non-wire localization techniques? Well, from my standpoint, probably one of the greatest advantages is I am decoupled from surgery. I no longer have to worry about the surgery schedule and the breast center schedule and canceling patients. Another nice thing about using a non-wire localization technique is I don't have to worry about wire migration, no going to the OR because one of the old Homer needles has migrated. There's no issue with wire transection. The surgeon can do any surgical approach, no matter how I place the tag. And then the patients who have had wire lokes and non-wire lokes, they love it. They are so happy to not ever have a wire localization again. Other advantages that my surgeon tells me and Dr. Blackwood can discuss are they're not affected by cauterization. They can be placed anytime greater than 30 days prior to surgery, as long as the intent is to remove it. They can be used for neoadjuvant therapy. Each tag has a unique ID, so you can place multiple tags in for bracketing or for multiple lesions. And there are multiple deployment techniques, especially with ultrasound. The tag is highly visible under ultrasound. What are the disadvantages? Probably the most significant disadvantage is cost. It's not inexpensive. The lesions and the tags that you place them in have to be at least 2 centimeters apart. If you place one inadvertently in the incorrect area, there is no repositioning after deployment. One disadvantage of the way the applicator system is made, it is a 12 gauge needle, so it's a larger needle than you typically use for localization. And then there are issues with the depth, and I'll let Dr. Blackwood address those. Again, the deployment options are mammographic guidance, stereotactic guidance, and ultrasound guidance. I use probably mammographic and ultrasound guidance the most. Now, what do they look like? These are the needle applicators for ultrasound. They come in a 10 centimeter, a 7 centimeter, and a 5 centimeter length, and they have a small locking device on there so you can't inadvertently deploy it. These are the S applicator needles that are used for mammographic localization. They have a radiolucent hub so you can see through that and as you're positioning your localization. So how do I do it? Well, like I said, I try and use mostly a mammographic technique if the lesion is not visible under ultrasound instead of the stereotactic technique. This is a tray that is routinely set up. You do not need this much lidocaine. That's just our standard setup. You do need a small scalpel with an 11 blade to make a small incision for the 12 gauge applicator system. Sorry about that. And you really don't need the surgical towels, but again, that's just something my techs and nurse are used to setting up. This is the localizer or the reader system here. And one of the things that we always do to start is we always We always check the ID to make sure that the ID in the needle applicator and on the reader system, the same number comes up, and we make sure that it works. I've not had any problems with them not being able to detect it, but just always to be careful. So how do we do the mammographic technique? Well, I've put some images in here. This arrow is a patient who needs a biopsy of this small mammographic mass. She also has another clip in from a prior benign biopsy. So we did that biopsy. We placed a cork marker in place. That came back to be an invasive ductal cancer. So now we're going to localize it for surgery, and I've marked the arrow where we're going to go. You can see that there's the clip. The lesion, though, looks like it's almost gone after the stereotactic biopsy, but you do the standard mammographic technique with the alphanumeric grid, and here's our marker that we're going to localize. This is what it looks like with the patient in position. We've marked it to get our coordinates. This is the corresponding view of what the patient is looking like. So once I have that, I just numb up the breast like you typically would for a wire localization. Notice though, we are making a little tiny incision for the needle applicator system. This is the needle applicator system with the S-shaped curve on it that I showed you before. Here's the corresponding mammographic picture when that is placed, and you can see here's that ribbon clip that we're not localizing. Here's this small cork clip that you can see right through the radiolucent hub. Then we obtain the orthogonal view. The patient is now in the cranial caudal view. And then this is the corresponding, the corresponding mammographic image here with the tip at the clip where the device is going to be deployed. So once I have the tip at clip, I typically deploy the lesion with a push deployment. You need to remove that small S lock from the needle applicator system and then just push the button. This is the post image right here demonstrating. Here's the clip that I just localized. Here's the CC view, and then here is the straight medial lateral view with the cork clip and the tag localizer together. And then one final thing that we do each time, I go ahead and lie the patient down and I check the clip. I check the tag to make sure that the number comes up. That should be coming up on the display here on the reader device. And I do have the patient supine just because that's how the patient is going to be in surgery. She's going to be supine. And then we go ahead, since we have a PACS system, we go ahead and print the images, and I put the tag number on the image, and then these are scanned back into the PACS, and then they're also sent to the OR with the patient. So that in case there's any issue with the PACS, the patient can still have surgery. Now, how is it different from the ultrasound? If you do an ultrasound localization, well, you're using a slightly different needle application system. This one is the same thing. It's a 12 gauge needle device. It comes in 10, 7, and 5 centimeter lengths. There are hash marks on it indicating 1 centimeter. There's a bevel indicator. And then there's a lock, just like on the mammographic needle application system. So if you're going to do an ultrasound case, I've pulled out a case that has multiple lesions just for ease of localization. Here's a small lesion at 7 o'clock and one at 6 o'clock. These are their corresponding ultrasound images. Same thing, I'm going to check the tag to make sure I'm getting the ID to register. I'm going to numb up the breast, which is what I'm doing here. I'm making, again, the little tiny skin nick. And then I'm advancing the applicator device into the breast, just like I would be doing with a regular wire localization. This is what it's going to look like. This is with the bevel directed towards the mass. And then here is the bevel actually in the mass. And at that point, I'm going to deploy the tag device. I'm just showing you here how easy it is to unlock for ultrasound deployment. I can do that with one hand and not lose my position pretty easily. And then once I've deployed it, again, here I am again checking for that signal with the tag and the number. And then also on that display, here it is, it tells you I'm 32 millimeters from the tag. The patient's lying down just like she would be in surgery. So what does your ultrasound image look like at that point? This is the 7 o'clock lesion, the smaller one. This is with the tag right through the lesion, and you can see it's readily visible. I still measure for the surgeon. You probably don't need to do this, but it's just a force of habit. This is the second lesion that was in that original mammogram. This is the lesion at 6 o'clock. Again, here's the bevel headed towards the mass. Once the bevel is in the mass, then I go ahead and deploy it, and here is the tag. Again, you can see it's readily visible on ultrasound. So what's it look like after you do the localization? These tags are actually right at 2 centimeters. The surgeon did not want me to, sorry about that. The surgeon did not want me to put a tag between the two. He wanted to make sure that they remove both masses in totality. So I placed a clip in with the vision clip and then one with the ribbon clip, and those were just at 2 centimeters. I was able to get 2 unique tag identification numbers that didn't interfere. And then here's the specimen radiograph. You can see here is one tag with the ribbon clip. Here's the vision clip with the second tag. And this is just another view. Here's the vision clip with the mass. And here's the second tag with the ribbon clip, and that mass is really hard to see after localization. Okay, so can you have challenges and how do you overcome them? Well, what if your lesions are too close, or what if you misplace one of the tags? Then people ask me all the time, do you have migration of the tag? And I've had a little bit of migration. I would say I have more migration when I do stereotactic placement of a tag than I do with the typical mammographic localization. And why do I think that is? I think it's probably from the accordion effect. Then there's some other issues. If you have an inferior lesion and you really don't see it on ultrasound and you're trying to locate mammographically, that can be a problem because the device is a little heavy and it can fall literally out of the breast if you're coming inferiorly. The other issue is with the 12 gauge deployment system. Sometimes it can be hard to push through the breast with ultrasound, but there's an introducer that you can use to make that easier. So what about lesions being too close? One of the things that we started doing, if the lesions are really close, you can see here's a clip here and here's a clip here in the straight medial lateral view. Both of those are cancer. Here's the clip on the CC view. They're actually fairly close together. I was a little concerned about having localized 2 of those with 2 different tags. So I just told the surgeon we're going to put it right in the middle. And here's the tag with the lesion right in the middle, with the tag right in the middle, and then the specimen radiograph. Here are both clips, and there's the tag. So the surgeon had no problem excising those 2 breast cancers with that one tag placed in between the 2. What about misplacement? So I've placed this mammogram image here just so you can see this calcification that the arrow is pointing to. Here's the calcification. Here's a little tiny mass in the breast that turned out to be a cancer. This is what it looked like on the ultrasound. And then I went ahead and biopsied it and left a vision clip in place. Here's a vision clip. There's the cancer, but note that calcification right there. So when it came to localizing this, we decided to do it under ultrasound guidance. And here's what I thought was that vision clip. And I went ahead and placed the tag, and you can see, look how easily visible that tag is. And then I went and obtained the mammogram, and I noticed that I had localized the calcification, but not the tag. Here's the vision clip. Here's the vision clip, and the tag is actually adjacent to the calcification, which explains why it was so hard to see. So once we realized we'd localized the wrong thing, we thought, well, it looks like they're far enough apart on the straight medial lateral view that maybe we could place a second tag mammographically. So we went back to our old alphanumeric grid, and here's the image of the needle localizer clip right at the needle applicator. And so remember what we say, tip it, clip, it's time to deploy. So we deployed the lesion, the tag, and we have this view in the straight medial lateral showing that now we have the tag adjacent to the vision clip, which is the cancer. We have a tag adjacent to the calcification. In the straight medial lateral view, they are 2 centimeters apart, and we were able to get 2 unique ID numbers. So the surgeon felt pretty confident it wouldn't be a problem for him to remove the tag adjacent to the cancer and the other tag that was placed next to the calcification. Now, fortunately, he was able to remove the tag here where the cancer was. And then he was able to localize the second tag without removing any breast tissue. And then he took a specimen image of it. And that's important because the tags are meant to be removed. So we just wanted to document that we had both tags out of the breast. So if you do misdeploy something, as we did, there is always, if it's at least 2 centimeters away, you can easily place another tag. The surgeon that I work with thought it was no problem to go after that second tag and easily removed it. Okay, so there's always a question of migration and how much of an issue is it? So here's one case I have of that. Here's a mass in the left breast that's obviously right here at the 6 o'clock position. You can see it on ultrasound. It's pretty easy to identify right beneath the skin. So that was biopsied, and then a little tiny ribbon clip was placed in that mass right here at the anterior inferior aspect. So that turned out to be another invasive ductal carcinoma. Here's the image of the mass, the little tiny ribbon clip that was placed in it. So we went ahead under ultrasound guidance and we placed the tag. Here's that tag marker. Again, you can see how how well echogenic it is. You can easily see that under ultrasound. So from that point, and you can see it looks like it's right in the center of the lesion. From that point, we went and took the patient for a mammogram, and you can see right here where the tag is kind of backed out of the mass. That was what we had deployed in ultrasound. So I have had a few issues with migration, but you can see it's very minimal in this case. And what I think probably happened was the tag backed out along the track that we placed it in. And as far as the surgeon really had no issue obtaining the mass with the clip, and then here's the tag that was removed. So you can get some migration, but I've not had it be a significant issue that the surgeon has not been able to remove the lesion. So just kind of in summary, how do we overcome challenges? Well, the challenges that you can have are inferior lesions that may be very difficult to assess from a medial lateral approach, or if you have a patient who's not going to be amenable to doing an upright stereotactic or mammographic placement, you can use the prone table and use the lateral arm. I've done this several times, and that seems to work well. When you do stereotactic placement, I feel like there's more of an issue with the accordion effect. It doesn't always happen, but it seems to be a little bit more occur more often with stereotactic placement. And then finally, you're using a 12 gauge device, which can be difficult for ultrasound placements. So you can use an introducer that comes with the ultrasound deployment system if that's helpful to you. But once you kind of get the hang of it, there's a little bit of a steep learning curve, but it's been relatively easy to use. And I know the surgeons I work with really like this device, and that's their preference. So thank you very much. And I'm going to turn it over to Dr. Blackwood.
So thanks, Colleen. That was a really great talk. And I really felt like I was right there with you doing those cases. And this really is a combined approach with radiology and surgery. The radiologist and the surgeon in our institution, the radiologist places these localizers. And of course, we, the surgeons, do the surgery on these patients. I'm just going to go over what we have found in our institution. We have about 18 breast surgeons throughout our service. And we have looked at many different techniques throughout this time. So I'd like to share with you our experiences from this. So going wireless is obviously a really great step for most breast surgeons and most radiologists, obviously. It's sort of been, this is filling a need that I think all of us have wanted for a long time. We never used to be able to start a 7:30 case in the morning until this was available. We had at our disposal at one point wires, which we still have. We have obviously the Hologic localizer, and then we have trialed the other localization techniques over time. We have finally landed after all the trial. We felt the best solution for us was the Hologic localizer, and I can tell you why. So as you can see, this is a picture of the localizer itself and the pen that comes with it. Let me go to the next slide. So at the top, you see the looped probe, and you saw in Colleen's talk that when she's looking for the ID tag or the tag number, that she uses the looped probe in this area. You also, when you take this out for the OR, this is the actual handheld device is not sterile. It comes with a sterile sleeve, however. The sleeve is easy to put on, and the surgical probe itself is sterile. And then you plug this in through the little plastic envelope, which is very easy. You turn on the device down here at the power button, and this gives you a distance display from the tip of this surgical probe to the actual Faxitron the Hologic localizer. Also the battery, the display here really helps you because when you see that tag ID number, you know you're in the right area. Today I did, I guess, 4 cases with the Hologic localizer, and on one of my cases, the number was not coming up. So I knew I had to basically cut down through the subcutaneous tissue a little bit deeper, and then my came up as 3.32 millimeters, and then it was a very posterior lesion. And then I kept my dissection going down a little bit further. And then once I keep checking it with my surgical probe, and then once I see that number pop up, not just 3 question marks, then I know I'm in the right spot. So if you look at the number 1 up here, the signal comes from the RFID tag. The tag, if it's placed in the horizontal like this, and the probe is coming down towards it, it creates a circuit through the tag that flows through each end of the pole. Interestingly enough, when you're parallel to the axis, meaning that your probe is coming in at the edge, no matter how far apart you are, you get your strongest and most precise signal that's emitted from that pole. However, and that's where you really see the number come up. However, you can still, even when the probe is off axis, you can still find your tag. What I have found that helps the most is our radiologists really help us out the most, I believe, by putting this posterior to our cancer lesions. And this way I can use my x-rays and my distance to know sort of how far to create my dissection down to. Then when you get number 4 shows you what happens in the perpendicular axis, you still get a reading, but it says 0 distance along that shaft. So honestly, it's, I think, a little bit difficult using your CC and MLO view x-rays to know if you're in the if you're parallel to the probe, to the tag or not. But the biggest thing you'll notice is when you see that tag ID number come up, you know you're in the right spot. So the rule of thumb, of course, when you see this, the smaller the number, the closer you are to a pole. So if it says, 2 millimeters, 3 millimeters, you know you're very close. So what are the advantages? I think the advantages are pretty obvious to most of us who do this on a regular basis. You really get to control your surgical schedule. You can put the tag in at any time. Some places are putting in at the time of their biopsies. It used to be that there was a 30-day window, but that no longer exists. If you want to put it into a tumor before neoadjuvant chemotherapy, that also is allowed. It's great that you can have 4 cases like I had today. One of the cases actually had a bracketed lesion. So there were 2 localizers in it, and I'll talk about that a little bit later. But literally my OR schedule flowed beautifully today. I one case after another, because these patients had had their localization done over the last couple of weeks. A lot less patient stress. I had a patient today who had a previous wire localization a number of years ago in the other breast when she had a cancer there. And she told me that this was a much more pleasant experience. She did go for her sentinel node injection today, but that was it. And then she was ready to go in the operating room, and she didn't have to worry about having any sort of wire put into her breast today or tag. So she compared both and gave me, without me even asking what she thought of it, she gave a positive review. I don't know that it's a less surgical time per se. My surgical times are about the same, whether I use a wire or a wireless RFID tag. I definitely am taking out less volume of tumor. Once you get used to using this, of course, there's a learning curve with anything. You'll find that it's relatively, it's not relatively precise, it's precise. Especially if you work with a radiologist like Colleen Madden, you really, once your radiologist is used to this and you guys come to an agreement on where you want these tags placed, it's really it leads to a nice day in the OR, a lot less stress for us too, not just for the patients. I do love the bracketing. I had a bracketed lesion, a long area of DCIS today, and I was able to use 1 incision. I was able to localize both tags prior to even making incision. So I was able to plan my incision. And that is really helpful, particularly if you're doing an oncoplastic mastopexy with a wise pattern incision. If you have a bracketed lesion, you know that you're getting both the posterior and the anterior lesion itself. And then, of course, I get an X-ray of the specimen in the operating room, and I know that I have both tags out, and I know I have my bracketed lesion, and I see my calcifications. I too had my first case, of course, when we started doing this a couple of years ago. My first case, the radiologist had deployed the tag in the wrong spot. So she went ahead and placed the tag in the correct spot. And then we, of course, had a discussion prior to surgery, and I was able to retrieve the other RFID tag without any damage to the breast, just through a small dissection lateral to where she had placed the lesion in my cancer case that I was doing. We also got an specimen X-ray of everything just to confirm that we have everything out. But the bracketing is great. I really, with the other localization techniques that I've used, other than wires, I've never been able to really get a bracketed lesion. I also found that when you're bracketed with wires prior to this, I ended up taking out a lot more tissue rather than the duct itself with the calcification. So I like that. An office-based procedure, you can do this. As I said, the ultrasound neoadjuvant chemotherapy patients, you can place it in any time. If you want to place it yourself, we don't place our own. At our institution, our radiologists place it for us. But I also have found that if it's a really deep lesion and they've been placed prior to the neoadjuvant chemo, so one of my surgeons uses an ultrasound machine in the operating room to find it, and that too has been very helpful, because as you know, many times there's no real pathology that's left in the breast, but the clip and the sometimes calcifications, but the RFID tag. The more advantages, of course, there's no special regulatory requirements. You don't have to worry about radioactive seeds. We had looked into radioactive seeds at one point, but it was very difficult here in New Jersey to handle the radioactive seeds. We are on different campuses from the hospital. We would have had to get another licensing agreement, and then it would have to be transported to pathology. It was just very, very difficult for us to even go down that pathway. We had looked into that about 4 or 5 years ago. There's no issues with lights or, if your OR lights are on, it certainly doesn't hurt. Most of us like to operate with lights on. So I found that helped. Another technique that we tried with the seed, I found that if you don't have titanium instruments, and we didn't for every case, that it got in the way if you had stainless steel instruments. We didn't have to worry about nickel allergies for patients. The probe itself, which is attached to the localizer, is disposable, whereas this obviously we keep from case to case, and then we just get a new probe and plug it in and then turn it on, and we get our readout. Cost, of course, is any of these new ways of doing it is a little bit more costly than a wire, but I think convenience factor and time in the OR is much less. We are in and out of the OR for a lumpectomy, probably about 30 minutes total. MRI bloom is something that people are always concerned about, of course. We don't really see a lot with the RFID tag if it's placed with a neoadjuvant case ahead of time. This is a display of images. These are 3 different lesions in the breast. You can see across the area. Obviously, one looks like a lymph node and one has the RFID tag inferior to it. This is the sterile envelope that the handheld piece comes in. Again, you can scan the patient ahead of time with the circle at the top, just to make sure what your number is before you go in if you want. Then I usually hand it to my scrub nurse, and she opens the envelope for me and I slip it in, and then it's easy to fold over and keep sterile. And then there's a little piece at the top that you open that little envelope, that little tag or that little covering, and you can plug your probe in very easily. Again, the probe is the sterile part. I like the idea that this is handheld by us. I have to say the display, sometimes when you have very bright OR lights, you have to kind of move your localizer handheld piece around. Let me turn it off, but you have to kind of get it out of the light so that you can see it a little better in the display. Because sometimes our OR lights are thankfully very bright. Then this is what I was talking about, where you plug in the probe into the handheld localizer. And this is what it looks like in the operating room. Again, you can scan with the little loop on the end, and you can also scan with your probe. As you can imagine, many times, particularly today, I had some lesions that were near the nipple-areolar complex inferiorly. So of course, the radiologist had come in through a lateral approach. Sometimes there's a little hematoma right near there, which helps you find it. But I always scan the patient prior to prepping and draping. This way I have a nice approach that I'm using ahead of time. So this just shows you as you press. So when you make your small incision, you can see this through 33 millimeters. You cannot see on this display the number, which means you're probably pretty far away or not in alignment with your RFID tag. So if I'm too far away to see my number come up, or if it has a question mark that comes up on the display, the tag ID number will come up later as I dissect down towards it. There is a learning curve, like with anything else. Some places when they're learning, I know a couple of surgeons who wanted the wire and the RFID clip at the same time. I think if you're pretty comfortable being in the operating room and you can read your mammogram, and you have your mammograms with you, either by the PACS system or the actual films themselves, I don't know that you need the wire. We did not use the wire when we were in our learning curve, but we had used several of the other types of localizers prior to settling on the hologic localizer. So most of my surgeons were comfortable with this. The radiologist sometimes at the beginning did mark a little circle for us prior, but the issue with that is if they do it a week or 2 weeks or 3 weeks ahead of time, usually that circle or that X is gone by the time of surgery. So I just found it's better to mark the patient prior to scan them ahead of time before you prep and drape them. And then you can plan your incision better. And maybe that'll take away. I also think it's not a bad idea to have someone with you when you're first doing it. We have 4 surgeons, 4 of us operate in one surgery center. So when we were there that first week or 2 that we were using this, a lot of us were operating. So we would go into each other's rooms and kind of work together in the beginning. I'm just going to show you a couple of cases. The first case is a 73-year-old female with a left invasive ductal carcinoma. It's 10 centimeters from the nipple, and the tumor itself is a T1 lesion, 1.6 centimeters. So you can see this is the CC view here. Nipple is right here. You can see this lesion. This is the biopsy clip, and here's the RFID tag. The RFID tag, and this is the MLO view. You can see how far from the nipple this is. So I was able to make a very lateral incision. Now we have learned a little bit. This is anterior to lesions. Some people like their RFID tags anterior to lesion. At this stage, our radiologists and most of our surgeons have come to the point where we really like the tag to be as posterior as possible for us. And that helps, particularly if you have calcifications that are headed back towards the pec major. So here the patient has been injected with the sentinel node with the technetium blue as well. And here is where you can see actually a little bit of a hematoma there. And then the incision, you can see up here is for the sentinel node incision, and this was for the breast incision. You can make your incisions kind of anywhere with this. That's one of the other nice things. So if you like to do oncoplastic reconstructive work or use a wise pattern incision, it's really nice to be able to have this capability. So this is a specimen radiograph, obviously. Here's the RFID tag. Here's the, the ribbon biopsy marker, and of course the cancer here, and looks like a nice margin all the way around it. Case number 2, 74-year-old female. This is an invasive lobular, 5 centimeters from the nipple, but it has 3 centimeters of microcalx with it. So this was a bracketed lesion. So you see there's an RFID tag more towards the nipple, and then one posterior, and then you can see your biopsy clip here. Again, injected with the methylene blue for the sentinel node. And this was the placement of the 2 clips. I was able to use 1 incision radially for the tumor itself, and then a separate incision, as you can see, for the sentinel node, sort of in the skin fold up here. And this way, both the 3 centimeters of calx, the tag, and the 2 RFID tags can be taken out. Again, specimen radiograph shows that. You can see the calx in the middle. There's the biopsy clip, and here are your 2 RFID tags. They have completely separate tag ID numbers, so you know exactly how far you are from each, and you can measure that really nicely with your probe. So a lot of times what I do is I plan out my incision when I get in there. I measure how far apart they are on the skin, and then I try 1 incision to be sort of in the middle of it if you can, if I'm not using a wise pattern incision. And then I cut down, I dissect towards the most anterior lesion, and then I swing around laterally usually and go towards the posterior lesion. And then I approach it sort of circumferentially. Throughout the case, especially on these, I'm usually testing to see how far apart I am from each lesion. I love the idea of bracketing the calcifications, or if you have two lesions, like Dr. Madden showed you before, I think that's a great way to make sure that you get all your lesions out, and really serves this breast conservation role that we want, with with the minimal amount of breast tissue removed. Case number 3 is a 61-year-old female. She had neoadjuvant chemo for a right invasive ductal carcinoma. She had an adjacent lesion that was seen. One was at 10 o'clock, and one was 9 centimeters from the nipple, one was 10 centimeters from the nipple. And then, of course, there's always another, as you know, a lot of times we'll find another lesion that we don't biopsy. But in this situation, we want to take out all 3 lesions at the time of surgery. So you can see there's a biopsy clip here, a biopsy clip here, and a biopsy clip here. And again, here and here. You can't see the more posterior one. These 2 RFID clips were placed at the known cancers, but I knew that I would go posterior to that. So again, able to use one incision to take this out, separate incision for the sentinel node. Sometimes if I think I can reach the sentinel node, I will take out all 3 lesions and the sentinel node through this upper outer quadrant incision. If I do that, I tend to put a drain in to close that area up. So let me show you what the specimen radiographs looks like. So this was that more posterior lesion with the clip and the RFID clip. This was one of the tumors that had shrunk down, and this was the other lesion. These are some citations, but I personally have found this to be a great technique. No technique is perfect, and this is definitely a learning curve to this. I have tried multiple techniques and multiple companies, localization techniques over the past, I guess, 4 years now. And we really have settled, our group has settled into this. The hologic localizer for us serves us beautifully. I find it to be very, very reproducible. Our radiologists agree that there is a learning curve as well. I'm sure Dr. Madden will tell you that as well. It is a little bit bigger than what they were used to with the other, the Scout that we used. I have to say, one of the other techniques that we were using in the beginning before hologic localizer was available to us, failed about 30 to 40% of the time. And there were a lot of blame on the surgeon. One time I was doing a bilateral case with that, and one breast it would work in, the other breast it didn't work in. That is a really amount of stress that in the OR that you just don't have to deal with the hologic localizer. And I find that it's reproducible. It works. The patients are comfortable. But I will say that, you know, and it's not that there are not other techniques out there, but for this tends to work for us. So
thank you both.
Questions. Yeah, sure.
Yeah, we have a couple of questions in here, but I'm going to first kick off the first questions. How many cases have you both done with the system, and how long did it take you to feel comfortable with the localizer system?
So I've had the benefit of having the hologic localizer now for 2 years. We actually started right about when COVID hit. Great timing. And we were doing everything at an outpatient surgical center at the time. And we had, thankfully, hologic localizer was available to us because here in New Jersey, a lot of things shut down. So this was a real blessing for us because we were able to do our surgeries. So I probably do 5 to 8 cases a week. So for 2 years, I mean, I did take a week or 2 off for vacation. Maybe I'll need a few more weeks vacation, and my group we at one of our other surgery centers and one of our other hospitals, we had another competitor's product, and all of them have asked me to switch. We're in the process of switching over all to hologic localizer. Not having a failure in the OR with the localization technique is really important to a surgeon.
Sure.
And the idea that you blame it on the lights or the instruments or the sunbeam, I don't know. I just don't think you can do that. I think that some of those ones with the little antenna, I think there's something damaged about them to begin with. I mean, one time they blamed the lights, then they blamed the bovie. I hadn't even made an incision yet. There was no bovie to blame. So, you know, this has been the most consistent product for us. Again, and I also love the idea that this is in my hand, so I can really look at the display. So I know that, I don't know if this comes up. Yeah.
Yep,
So I know that this is, you know, under my control. I don't have to worry about the nurse pushing the button again, restarting it, seeing if that's what's working. If for some reason the probe doesn't work, this doesn't work, they should match. So I have this on the handheld, and then I have this. I like being able to start it and stop it myself. I can mute it if I don't need it for a while, like while I'm doing the sentinel node.
Yep.
I like that control. I mean, I know that's not a surprise that surgeons like control, but we do.
You said it. Dr. Madden, you want to add anything to that?
Well, I was just going to say, so we started using it last July, and I do about, I don't know how many placements a week, probably somewhere between 5 and 10. So we've done several hundred now. I've not had any issues with significant migration yet. I've had a little bit. But one thing that I've noticed that Dr. Blackwood mentioned is it seems like it always works. When we were using the Savvy device, if they couldn't get a signal, I'd have to run over to the hospital or to the outpatient surgery center from my independent breast center, and I'd have to throw on a bunny suit, and I'd have to get an intraoperative ultrasound and find it for the surgeon, because there they were in surgery and they couldn't get the device, they couldn't hear it. So since we switched over, I have never had to do that. The other thing I really like is the bracketing. With the other devices that we use, we really couldn't bracket if they were too close together. So I would still have to go over early in the morning at the hospital and do, you know, wire localizations if it was more than one area, if it was 2 areas or 3 areas. So it's been one of those things. I didn't really have a preference for what we used. I just wanted to use a non-wire device, but my surgeons absolutely love the Hologic. So I was like, I'm going to figure it out. Whatever it takes, if they love it, I'll make it work.
Good. Thank you, Dr. Madden. Thank you. So again, if you have questions, please submit them through the Q&A. We have a few in here right now, so I'm just going to go right down into them. The first question, can you deploy the tag using Tomo guidance? We'd like to take that.
That sounds like a Dr. Madden question.
Yeah, it's a good question. Yeah, you can use stereotactic or Tomo guidance. And like I said, I've done it several times. I've done it on the prone table. I've done it on the upright table. But honestly, if I can just do a mammographic approach I take 3 pictures, I'm done. And it just seems like I'm doing less radiation to the patient. And I could have brought one of our Tomo cases that I did on our lateral approach from the prone table. But yes, you can do stereotactic or you can do Tomo guidance. I guess I'm just old fashioned or old school. I just like doing the mammograph or the ultrasound and only doing the stereotactic or Tomo if I have to.
So just to add to that, our radiologists, and I was telling Colleen this before, they do like to use our stereo table for it, because our stereo table is also has Tomo capability, thankfully, because it matches our mammograms now. So they are very comfortable, and our table is prone, so the patients are lying down and they don't see it. Maybe that's why they like doing it that way. And of course they place it with ultrasound. But for whatever reason, our radiologists are very comfortable using our stereo table to place these things. And it really doesn't take them long at all, thankfully, with the new image guidance on our Hologic table for that. And then they do take the patients off of there and get my films for me, of course, right, because I use the films in the operating room to plan out my incision.
Yep, good. Thank you. Let's see here. Do you ever place wireless localizer clip for Biorad's 5 lesions instead of traditional clips?
So I'll let Colleen answer, but I'll tell you what happens here. We are a referral site. So one of our institutions that refers to us, if they feel that it's a BI-RADS 5 or they really are very sure it's a cancer, or no matter what, even if the pathology they think is going to come back negative, but the lesion still has to come out. We all have those cases. They will place a localizer at the time of the biopsy instead of a clip. And I'm okay with that. I don't have a problem with that. I think it does limit where the patient goes for the surgery, but since they're going to come to us, I'm good with that. Because if you go to a place, if the patient has, say, the hologic localizer and the surgeon doesn't have access to that technology, then that patient either has to get a second loc of some sort, or they have to go to a surgeon that uses it. We all know those lesions, even if it comes back not cancer, you're taking it out anyway. So I'm okay with that. I don't know, Colleen, do you do that?
Yeah. Yes, I do. And it's the same thing, just like you said. If I know that the patient is going to stay and see one of our surgeons, I will definitely put it in if I know it's a BI-RADS 5 or if it's a lesion that's going to come out. When patients don't know where they want to go or who they want to see, then I don't, because just like you said, different sites are using other procedures or they still use wire localizations. So I'm just careful. If I know they're staying, then yes, I do.
Great. All right. Who led the rollout of this technology, the radiologists or surgeons in your practices?
That's a good question. That's a really good question. So in my institution, it was me, the surgeon. I've been trying to uncouple the times for the OR. I'm a morning person, like most surgeons, and I love to get in the OR relatively early and have, 4 or 5 or 6 cases in a day. We were waiting. I had block time before this that had to match the radiologist, and my block time was 9 to 3. But the problem with that is if they had trouble with the loc in the morning, the patient sometimes didn't come upstairs until 10 or 10:30. And then that set the whole day back. And it's not good for your OR staff. They're trying to plan their lunches and their breaks. It's a much more controlled schedule now. So for me, again, maybe it's my control issues, but I did ask our radiologist to help me explore the different options. We have a number of surgeons, as I said, and all breast surgeons. And I did ask them to weigh in on the different techniques. We did trial a number of we trialed Savvy Scout, Magseed, and of course, hologic localizer. So, and our radiologists obviously have to be our team with that because they're the ones placing it. So thankfully, they were really good sports about it, very flexible with us while we were all learning the techniques. And then we all settled on hologic localizer. And my radiologists are fine with it, just like Dr. Madden is. They're not intimidated by it.
And at my institution, I initially instituted it. In 2016, I tried to start the radioactive seed program that Dr. Blackwood mentioned. And then I realized, because my breast center is not at the hospital, that it was going to be a nightmare. So after I discovered that was going to be a problem, then we started using the Scout at my request. And then the surgeons are the ones, actually what happened was one of the hologic reps' daughter was a nanny for the surgeon. And so you know what they say, it doesn't matter what you know, it's who you know. So the nanny started telling the surgeon, hey, my mom sells this really cool device you should use in the OR. So then they came back to me and said, hey, we want to switch to this. Will you do it? And I'm like, whatever you want, I'll figure it out. So to be honest, to switching from what we used to use to this, it was the surgeon, because the nanny's daughter was one of the hologic reps.
This is undoubtedly a first, because the nanny said, but thank you.
The nanny told the surgeon, my mom sells this hologic device, you need to use it.
That's good. That's a first for me. So this is a two-part question. Can you elaborate on the 30-day window clearance being extended? Is there any harm if it is not removed? And then the second one is, can it be deployed under MRI? So who'd like to take that?
I've been doing this so long that there used to be, first there was a 7-day window, then there was a 30-day. And I know that several of our neoadjuvant patients, which, as you know, neoadjuvant chemotherapy is usually about a 4-month process, maybe 5 months before surgery. We've had no problems with it. I always was a little concerned, and I always did scan them ahead of time with this so that I made sure that it was still working. But yes, it was still working. So I didn't have any. I did worry about that glass being in there, but that also wasn't an issue either. It actually forms, it's a little bit more in the tissue when you take it out over after several months, rather than just the track that it came through. As far as MRI guidance, I'll leave that to Dr. Madden.
Yeah, I have never placed one under MRI. So Phil, I assume that it is MRI compatible and it could be done, but I've just never had that opportunity come up yet to do that. So I don't really know how to answer that, but I've done MRs on patients who've had tags in place, and you do get a little bit of bloom around the tag from the when you do the MR, but that's not really been a big issue for us.
Yeah, and I've done an MR afterwards, after neoadj, and I haven't had any issues. I see there is a question about the sentinel node in the OR. We're still using the double technique of the technetium, and then I do the methylene blue, dilute methylene blue. They do go to nuke med first prior to coming to the OR. I've, like everybody else, tried to decouple that. We will do it sometimes the day before. The problem is I have block time on Mondays, and with COVID, it was hard to get anyone to do that little tiny injection on a Sunday. So right now, like the patient I had today, I did the 2 lumpectomies first, and then I did the lumpectomy. The other 2 were later in the day, like 11 o'clock, and then 1 o'clock or 12:30. And they went and had their nuclear injection early in the morning. I don't make them wait for the lymphoscintigraphy. I don't use it because obviously I'm using the probe to find the lymph node, and I use the blue dye. So it takes, as you know, just a few minutes to inject the technetium. It's a tiny little needle. They give it with local. It doesn't hurt. And then by the time the patient gets to me and I talk to her and we get ready for the OR, and then when she's asleep, then I inject the methylene blue. And right now that's how we do it. I'm sure there's a couple of new ways that are techniques out there that we are definitely exploring.
Yeah, and my surgeons are the same. If they want to do a really early morning case that starts at 7 or before, as long as it's not a Sunday, we'll have the patient come the afternoon before, around 3:30 or 4, and we will do the sentinel node injection at that time, because then by the time they start in the morning, there's only 2 half-lives that have passed. So that's how we get around a patient having a sentinel node injection for an early morning case. Otherwise, we'll just do the sentinel node right before the patient goes to surgery.
Yeah, we do the 2:30 in the afternoon the day before, if it's not a Sunday.
Yeah, good. So 2 more questions here. One I think we already answered, but I'll still throw it out there. But first, for patients with heart monitor or pacemaker, can we still use RFID tags? Some heart rhythm monitors are quite a big rod across the breast. Will those monitors interfere with the RFID tags?
I've never seen any interference with my patients with pacemakers.
No.
Philip, is there any issue?
No, not that I'm aware of. No.
I mean, the defibrillators can be pretty big, but sometimes they don't place. I mean, if they're in the breast, we got another issue going on anyway.
Yeah.
And then I also, if I have a patient who really has to have a defibrillator, sometimes they don't become operative candidates. But I have a number of women who have pacemakers, and I haven't had any issues.
No. Okay.
And now
Yeah.
a lot of the pacemakers are even MRI compatible, so I haven't had any issues with that either.
Yeah, and the same issue, I've put them in patients who have loop recorders and pacemakers, and I've not had any issues, and the surgeon has not told me of any issues.
Yeah, why
So
we have to have those loop recorders in the breast is beyond me, but that's another story.
So this
It
last
screws up your
question.
MRI.
Yeah, I'm sorry, Dr. Blackwood.
That's
This
okay.
last question, I'd recommend asking your representative, because everything depends on your institution, but how much is one RFID tag? And are both the ultrasound and stereo deployers 12 gauge? I personally don't know, so I have to yield to both of you, please.
So I can answer that. Yes, both of the applicators for ultrasound and for a mammo localization, they're both 12 gauge systems. The ultrasound has an introducer that you can use because it is a little bit difficult to have that probe, have that applicator go through the soft tissues on ultrasound. You're kind of going like a snow plow through it sometimes if the patient has really dense breasts, so you can use the introducer. When they're compressed, like you would do for stereotactic or mammographic or tomo guidance, it's not much of an issue once you make the skin neck.
I think we're paying about $450 for an RFID tag. Although I think that price changes with the numbers you use. And I think I don't know, I think I shouldn't say that, but that's what I'm under the impression. Our wires have gone up. If you use Wirelog, just to let you know, they've gone up over $100. So they're not as cheap as they used to be either.
Right.
Yeah, I think ours are around somewhere between 450 and 500.
Yeah. Well, okay. Well, with that, I want to thank you both and just remind the audience to please visit www.hologiced.com, where we have numerous other educational programs, both CME and non-CME. If you would also please do the survey at the end of this presentation so we can get some feedback. But Drs. Blackwood and Madden, thanks so much. It's great seeing both of you. Appreciate the great discussion. Have a great rest of the night. Appreciate it. Thanks, everyone.
All right,
Take care.
you.
Bye-bye.
Bye.
Bye, Colleen.
Bye.